Entamoeba histolytica. It is an intestinal protozoa. Infective form of this pathogen is quadrinucleated cyst. So this quadrinucleated cyst is ingested. It goes to stomach. Then it causes excistation, and now this quadrinucleated cyst is formed into trophozoite. Then further, this quadrinucleated cyst gets divided, and one quadrinucleated cyst forms 8 trophozoites. So one quadrinucleated cyst forms 8 amoebas. 8 trophozoites will form 8 amoebas. Site of infection is most commonly, or site of this excistation is most commonly distal colon and cecum. So the cyst enters, and the excistation and infection forms at distal colon and cecum is the most common. Then we have virulence factors. Virulence factors of this Entamoeba histolytica are galactosamine lecithin, which causes binding, galactosamine lecithin, then protease enzyme, which degrades collagen. Then other virulent factors are colmidulin and phospholipase A, which inhibits neutrophils. Thioridoxine reductase, which degrades toxic O2 and N2 radicals. So calmodulin, phospholipase A, and thioridoxines. Now this Entamoeba histolytica forms flask-shaped ulcers at distal colon. This is trophozoite flask-shaped ulcers, and at distal colon the trophozoite again goes under the encystation, and this quadrinucleated cyst is ready to infect others. But in stool, both trophozoites and cyst will be found. Now diagnosis of is done by stool microscopy. So how to differentiate between pathogenic and non-pathogenic strains of this Entamoeba histolytica. So trophozoite, as we know that in stool both trophozoites as well as cyst will be seen. So trophozoites of a pathogenic Entamoeba histolytica are 15 to 20 micron in diameter. Then they are active. They have ectoplasma as well as endoplasm, and there are RBC and cellular debris in that trophozoite. In non-pathogenic, these are larger in size, 20 to 30 micrometer. They are not active, they are sluggish, and only endoplasma is present, no ectoplasm. And no RBC cellular debris is present. And bacteria may be present in trophozoite, these non-pathogenic trophozoites. So now this is all about trophozoite. Now cyst of the pathogenic strains will have will be 6 to 15 micron and have 1 to 4 nuclei. Here the cyst will be larger, 150 micron, and will have 1 to 8 nuclei. Now some more differentiations between this pathogenic and non-pathogenic are glycogen mass during uninucleate. Glycogen mass is present during the uninucleate stage of that cyst, and this is all about cyst. So glycogen mass is present in cyst, but glycogen mass is present during binucleate stage of cyst in non-pathogenic, while here uninucleate stage also has glycogen mass. Then chromatoid body is same in both cyst, pathogenic and non-pathogenic. Then as we have seen stool culture, now we proceed to rectal biopsy. There is flask-shaped ulcer in rectal biopsy. The zymoden analysis, of rectal biopsy will give electrophoretic mobility pattern of isoenzyme. So zymoden analysis will give electrophoretic mobility pattern. Then we have nested PCR. Nested PCR, multiple primer, genus specific, species specific primers are used, and multiple species can be differentiated at the same time. So nested PCR is useful for that. Then we have galactosamine lectin antigen detection by ELISA in stool. So GUL NAC ELISA, GalNAc ELISA. This is investigation of choice of Entamoeba histolytica. So among all of this, GalNAc is the investigation of choice of Entamoeba histolytica. Now, extra-intestinal amoebiasis of this Entamoeba histolytica, that is extra-intestinal spread of this amoebiasis, it is hematogenous spread. It spreads to liver, to lungs, to brain. Liver is the most common, and and in the liver, the right lobe, which is the posterior superior quadrant of the right lobe, is the most common site. This is about hematogenous spread. Also, there is direct spread. Cutaneous amoebiasis may be seen due to unhygienic practices of affected patient. Then diagnosis. Diagnosis of amoebic liver abscess is on radiology and on liver aspirate. When liver aspirate is seen, it is anchovy sauce colored pus. We cannot see trophozoites as they are at margin of cyst. So best to diagnose this amoebic liver abscess is do liver aspirate and do PCR on that aspirate.